Hello and welcome to this webinar. Today I'm going to talk about recommendation for immunization of a solid organ transplant and hematopoietic stem cell candidates and recipients. My name is Daniele Donà and I completed my medical training in Padua at the Department for Women and Child Health. During my residency in pediatrics, I developed a strong interest in pediatric infectious diseases, and since my third year, I work intensively with the pediatric infectious diseases team. So, while we are talking about vaccines today, as you well know, infection is a major cause of morbidity and mortality in pediatric transplant candidates and recipients. So far, numerous strategies exist to prevent infection, including infection control, antimicrobial prophylaxis, prospective monitoring, and of course, vaccination. As you can see from these slides, a recent paper published on JAMA by Feldman and colleagues showed that hospitalization for vaccine-preventable infections occur in more than 15% of solid organ transplant recipients in the first 5 years after transplant, with a rate up to 87 times higher than general population. For this reason, the authors say that due to the huge burden in terms of morbidity, mortality, and cost of illness from vaccine-preventable infection, all physicians must ensure that all transplant patients receive age-appropriate immunization. And this is particularly true given the recent occurrence of vaccine-preventable disease outbreaks due to declines in vaccination coverage, for example, measles and pertussis. When we refer to vaccine-preventable infection, we have to keep in mind that RSV, rotavirus, and influenza are the most common infections resulting in hospitalization, while influenza, varicella, and invasive pneumococcal infection continue to lead to significant morbidity and mortality. As you can see from these slides, infection preventable by vaccination represent an important part of post-transplant infection. Classified according to the timing of transplantation, these are generally the most common infection after the first 12 months. However, we can forget that even the patient who is a candidate for transplantation has a greater risk of infection. Vaccination play a pivotal role in patient protection. But remember, not only the patient needs to be vaccinated. The environment where the children live play an important role for their safety. Indeed, the protection is also ensured by vaccination of the donors, the family contact, the healthcare workers, and the entire community. And this is extremely important to take in mind. Let's start from the patient. Several challenges exist in the vaccination of pediatric transplant recipients. Both for solid organ and hematopoietic stem cell transplantation, there are only few prospective randomized controlled trials to determine vaccine efficacy, optimal timing of vaccine administration, predictors of vaccine immunogenicity, and correlates of protection. Indeed, the timing is the key point for optimized vaccination efficacy and safety. But evidence to guide optimal post-transplantation timing for initiation, continuation, or reinitiation of immunization is generally lacking in pediatric patients. Timing is important in both solid organ transplant and hematopoietic stem cell transplant recipients because administration of high doses of immunosuppressive medication in the form of induction for solid organ transplant or conditioning in hematopoietic stem cell transplant recipients could result in an effective vaccine response in the early post-transplantation period. Vaccines administered both in pre- and post-transplantation period may have a reduced efficacy. If administered before transplantation, after starting immunosuppressive therapy, a loss of immunogenicity has been demonstrated, while vaccine administered in the post-transplant period may have reduced immunogenicity and efficacy for a variety of reasons, such as immunosuppressive medication, underlying disease, rejection, and GVHD. Moreover, post-transplantation administration of live virus vaccine is generally not recommended for solid organ transplant or is significantly delayed in hematopoietic stem cell transplantation. Transplant candidates are more likely to develop a vaccine-induced immunity compared with the solid organ transplant recipient receiving immunosuppressive therapy. So, vaccines should be administered prior to plan the immunosuppression is possible. We have to keep in mind the vaccine response inversely proportional to the number of immunosuppressive drug use. So previous studies have found that mycophenolate use was associated with decreased response to influenza-vaccinated kidney transplant recipients, while another study evaluated the response to influenza vaccine in the setting of anti-T cell therapy, and did not find a significant difference with thymoglobulin versus basiliximab. Pediatric transplant candidates may be under or unvaccinated pre-transplant. However, the transplant candidate does not represent the ideal patient because they are generally suffering from a chronic disease, and his vaccination response may be not adequate. Also, to his young age and prolonged hospitalization, his vaccination schedule could not be updated. A multi-step pre-transplantation workup is therefore essential. Patients with end-stage organ disease should be vaccinated as early as possible, while during transplant evaluation, a careful review of immunization records and serology is recommended to monitor the vaccination response and possibly re-immunize with a booster dose. Wherever possible, seroconversion should be documented after 4 weeks of completing the course of immunization to ascertain adequacy of protection. While on ongoing immunosuppression, it may be prudent to monitor protective antibody levels to time booster doses properly. Once in the waiting list, it's extremely important to check and recheck vaccination to protect transplant candidates through re-immunization and booster prior to the transplant. So how we can provide the best immunization for our transplant candidates? First of all, routine vaccination protocols must be adapted according to the country-specific vaccination schedule. But when immunization schedule is not completed, the use of a catch-up vaccination according to vaccine history and serology provide optimal protection against disease in the shortest but most effective time frame. Take every opportunity to review a person's vaccination history and give them appropriate catch-up vaccines. According to transplant urgency, an accelerated schedule is recommended, as we'll see later, especially for MMR and varicella vaccine. As you can see from this slide, all the vaccination including vaccination schedule are recommended in pre-transplant period. According to current recommendation, to allow time for immune response, all inactivated vaccines can theoretically be administered at least 2 weeks prior to the initiation of immunosuppressive therapy, while all live vaccine must be given in the pre-transplantation period at least 4 weeks before transplantation. This should take place during pre-transplantation evaluation in solid organ transplant candidates and before the start of conditioning regimen in hematopoietic stem cell transplant recipients. We have to take in mind, however, that most of pre-hematopoietic stem cell transplant recipients are immunosuppressed due to the need for chemotherapy to treat their underlying hematologic malignancies, and this precludes pre-transplantation administration of live attenuated vaccines. To facilitate the administration, live attenuated vaccines can be administered on the same day with an activated vaccine, and 2 live attenuated vaccines can be administered on the same day. Otherwise, the live vaccines need to be spaced 20 days apart. As you can see from these slides, after transplant, solid organ transplant recipients and hematopoietic stem cell transplant recipients follow different pathways. Talking about solid organ transplantation, as you can see from these slides, immunity against vaccine-preventable infections wanes following transplantation, with no statistical differences in seroconversion between different types of organ transplants. These are some data that show that 1 year after transplantation, there is a decrease from high vaccination coverage to a lower coverage, but still higher than the immunological response obtained through a post-transplant vaccination. Also, in hematopoietic stem cell transplant recipients, studies have shown that the levels of antibodies to diseases that can be prevented by vaccination decrease during the first years after stem cell or bone marrow transplant. The immunities acquired by the patient prior to the transplant are generally lost. So, post-hematopoietic stem cell transplant patient should be viewed as a never vaccinated, regardless of the pre-transplant status. This can occur after both allogenic or autologous transplantation, and in addition, while some immunity may be transferred from a donor, this is generally limited and can be relied upon to prevent infection. Chronic GVHD increases the likelihood to immunity to be lost. In stem cell recipients, post-transplantation immune recovery begins with engraftment of neutrophils, but lymphocyte recovery is a prolonged process. Reconstitution of the immune system requires at least several months post-transplantation, and some patients continue to have immune deficits for several years after transplant. In general, inactivated vaccines can be administered starting from 6 months after transplant. The 6-month vaccination time point is a good balance between vaccination made too early with low immune response and too late vaccination with high risk of severe infection. As much of previous donor and recipient immunity to specific pathogen is lost, hematopoietic stem cell transplant programs carry out a revaccination protocol that calls for conjugate pneumococcal vaccine, HBV vaccine, H. flu type B vaccine, polio, tetanus, and diphtheria. Recently, Carpenter and colleagues have proposed these screening questions to determine early vaccination candidacy after hematopoietic stem cell transplant. For considering early vaccination candidacy, the patient should not be receiving high-dose immunosuppressive therapy, despite which immunosuppressive therapy is able to prevent the effectiveness of vaccination has not been studied yet. We should evaluate if the patient have received an anti-CD20 antibody therapy in the previous 6 months, and if the patient is presenting a moderate severe GVHD. Finally, we have to evaluate if the patient has been treated with IVIG during the last 2 months. Even if IVIG do not inhibit immune responses for inactivated vaccines, the authors don't recommend early vaccination when the patient is receiving IVIG, because IVIG therapy is a surrogate marker for delayed immune reconstitution. So what is the best post-transplantation workup? So how we could ensure the best protection for our children? So post-transplantation workup consists in 2 phases. First of all, the evaluation of serological status and the vaccination history. Then, we'll be evaluating whether to continue with the regular vaccination program according country-specific schedule or completing the pre-transplantation vaccination with a booster dose. So far, no guidelines have been developed on when to measure antibodies post-transplantation, but a reasonable strategy would be to check and recheck titer between 6 months and 1 year after transplantation. We have to keep in mind that for some vaccines, no serological tests are available, and the only one we have today is measles, mumps, varicella, tetanus, hepatitis B, and hepatitis A. There are no clear indications on when to start vaccinating post-transplantation due to the effects of immunosuppressive therapy, but for sure, it would be prudent not to vaccinate during acute rejection episodes. An important aspect that I would like to stress today is the absence of association between vaccines and the development of organ rejection, while the infection themselves can result from triggering the rejection. Influenza immunization had been withheld in the past due to the fear of triggering allograft rejection, and this was based on case reports and small case series. However, larger studies have failed to support any clinical relevant association between immunization and rejection or allograft dysfunction. In solid organ transplant patients, current guidelines suggest to wait 2 to 6 months post-transplantation to improve vaccine immunogenicity. Thus, this guidance recommendation may be overridden in specific situations such as influenza outbreak. Live attenuated vaccines are generally contraindicated in solid organ transplant recipients due to the theoretical risk of vaccine-acquired infection due to lifelong immunosuppression. In contrast to solid organ transplant recipients who require lifelong immunosuppression, hematopoietic stem cell transplant recipients eventually reconstitute their immune system with a just pre-exemption. For example, GVHD that may experience prolonged periods of immunosuppression, and this can lead an impairment of response to immunization, or immune defects that can persist after transplantation. But in general, MMR vaccine and varicella vaccine are recommended for seronegative patients at 24 months post-transplantation, only if of immunosuppression, or have no GVHD, or without relapse or primary disease. Transplant recipients are at increased risk for developing severe or disseminated forms of infectious diseases from wild-type pathogens. And given there are growing safety profile and effectiveness data for select live attenuated vaccine, it is prudent for physicians to weigh the theoretical risk of vaccine-derived disease against the increased risk of developing severe manifestation wild-type pathogens due to underlying immunosuppression in transplant recipients. Recently, Croce and colleagues conducted a systematic review to estimate the safety of live vaccination in patients with immune-mediated inflammatory diseases and solid organ transplant on immunosuppressive treatment and in patients with bone marrow transplantation. Although the vaccinations were safe and sufficiently immunogenic, some serious reactions of vaccine-related infection were reported for patients with immune-mediated inflammatory diseases and solid organ transplantation. Apart from mild vaccine-related infection, MMR and varicella vaccines were safe when administered less than 2 years after bone marrow transplant. Let's talk briefly to the immunization in the donors. Living organ hematopoietic stem cell transplant donors should otherwise be up to date with the routinely recommended vaccine per the country-specific vaccination schedule. For organ transplant, non-live vaccine should be administered within 4 weeks of organ donation. In hematopoietic stem cell transplant recipient, studies have found that antigen-specific antibodies titer decrease over time after transplantation. Thus, transplant recipients are generally regarded as never vaccinated, regardless of donor or pre-transplant vaccination history. As we already saw, administration of live attenuated vaccine, especially varicella and MMR, are recommended as part of the post-transplant revaccination protocol in all seronegative hematopoietic stem cell transplant recipients at 24 months post-transplantation. So let's see now vaccination recommended for households. The importance for family members of being vaccinated is fundamental, in particular in the immediate post-transplantation period when immunosuppression levels and infectious risks are greater and children cannot be vaccinated. There are currently no restrictions of standard licensed vaccine that may be administered to household contacts of transplant recipients. No recommendations support delaying routine child immunization or isolation of immunized family members. Although the MMR and varicella vaccine is live, household transmission essentially does not occur. Rotavirus vaccine may be given to infants in the home of transplant recipients, but it is recommended that the transplant recipient avoid entering diapers of the infant for 4 weeks and should observe meticulous hand hygiene. Current guidelines also state that live traveler-related vaccine, for example yellow fever, may be administered to household contacts. Among vaccines administered to general public, the only vaccine for which household transmission was a significant issue in the past was the live oral polio vaccine, which has not been used for years. For countries in which the live oral polio vaccine is still in use, oral polio vaccine should not have been administered to household members of transplant recipients. The live intranasal influenza vaccine is not currently recommended due to suboptimal efficacy, and in case of transmission, household contacts should avoid contact with solid organ transplant recipients for 7 days only if they are severely immunocompromised. And what about the herd immunity? Herd immunity is a form of indirect protection for infectious diseases that occurs when a large percentage of population has become immune to the infection, thereby providing a measure of protection for individuals who are not immune. In a population in which a large number of individuals are immune, chains of infection are likely to be disrupted, which stops or slows the spread of diseases. The greater the proportion of individuals in a community who are immune, the smaller the probability for those who are not immune coming into contact with infectious individuals. And this is particularly true given recent occurrence of vaccine-preventable disease outbreaks, declining vaccine coverage, and a sustained increase in prevalence from several vaccine-preventable infections, such as measles and pertussis. Recently, WHO listed the vaccine hesitancy in the 10 threats to global health in 2019, together with Ebola, dengue, HIV, antibiotic resistance, pollution, and poverty, estimating between 2 and 3 million deaths a year are preventable with vaccination. WHO clearly states that the physician and nurses play a crucial role in influencing the correct decision regarding vaccination. Since physicians and nurses play a crucial role in influencing the correct decision regarding vaccination, are they vaccinated properly? Well, as you can see from these slides, despite almost a decade of efforts and wide recommendation for immunization of healthcare workers across the most European countries, vaccination coverage is still low in this group, and a significant difference compared data reported in US versus Europe and other countries exists. We have to keep in mind that the vaccination of healthcare workers continues to be a priority and vaccine uptake should be improved. The main objective of increasing vaccination coverage rates against influenza among the healthcare personnel can be reached through a well-designed long-term intervention programs that include a variety of coordinated elements based on educational programs focused on the risk association with influenza disease, benefits of vaccination, and reinforcing reason for vaccine acceptance. This relevant point is to be extended also to other vaccine-preventable diseases, such as measles, rubella, varicella, and of course pertussis.